I'm Joey Pop. Welcome to HealthWise. Imagine that you've been diagnosed with cancer. You seek treatment, but there's the constant fear that it will spread, perhaps to the bone. What are your chances for survival? What can you do to improve your quality of life? Well, that's our topic today on HealthWise, new treatments for the bone-related complications of cancer. With us is Dr. Jim Boyd, an oncology specialist from Charlotte. Thank you, Dr. Boyd, for being here.
Thank you.
And one of his patients fighting cancer, Donna Levin. Welcome to HealthWise, Donna.
Thank you.
How long have you been fighting cancer?
It will be 8 years in March.
And you look wonderful. Are you doing well?
I'm doing very well.
Well, we are so thrilled that you're with us today. We have many questions for you, but I'm first going to turn our attention to Dr. Boyd. If I've been diagnosed with cancer, would I come see you in the early stages, middle stages, later stages? Just what would be my relationship with Dr. Boyd?
I'm a medical oncologist, Joey, and we see patients with cancer diagnosed at all stages. We see them at early stages, such as early stage breast cancer or colon cancer or lung cancer, where we intervene to reduce the risk for recurrence. And this can be using chemotherapy or hormone therapy or a variety of other treatments to reduce the risk of relapse. And certainly we see a lot of patients who have advanced disease that has already spread to other parts of their body.
Which leads me into the next question. What cancers have the tendency of spreading to the bone?
Well, we have the most common cancers are breast, lung, and prostate. These are very common cancers anyhow, and they do have a tendency to spread to the bone. There are other cancers that also involve the bone. Multiple myeloma, which is a cancer that arises in the bone and bone marrow and can be devastating in terms of bone structure and pain. There are other cancers also, rarer cancers that can involve the bone, such as thyroid cancer and kidney cancer.
I believe we have a full screen, a graphic with the three that you mentioned at the top, and those being breast cancer, prostate cancer, and lung cancer. Are those the three most prominent that have the likelihood of spreading to the bone?
These are the ones that are most common to do that. They're common cancers in and of themselves, and they commonly go to bone.
Now, what is the chances of the cancer spreading to the bone once I've been initially diagnosed? Is it immediately? Does it take several months, several years?
Well, again, it depends on the stage of cancer. Let's take breast cancer, for example. Most women nowadays have their diagnosis of breast cancer made at a very early stage, stage 1 or stage 2. Stage 4 being spread to other parts of the body, such as to the bone. Many of these women will never experience spread of their cancer to bone or anywhere else. But
how encouraging.
That is. And some will, though, and that percentage varies upon the risk factors, but a certain percentage, perhaps 20 or 30%, somewhere in their lifetime, it may be as long as 10 years, 15 years later, may experience spread to the bone.
Donna, I'm going to shift gears to you now. Do you fall into this category? Has your cancer spread to the bone?
Yes.
And what type of cancer were you initially diagnosed with?
Breast cancer.
It was breast cancer.
Yes.
And the cancer went to the bone. How long a period before it went to the bone?
We detected my breast cancer in 1994 with a simple mammogram. I had a double mastectomy. 4 years later, I had a reoccurrence. And it was then that we found it in the bone in the upper thorax.
And you must have been devastated.
To say the least, yes. I was devastated. I never thought I would see it again. I felt that we had found it in a microscopic stage. I thought that my chances were phenomenal that I would never see breast cancer again. However, I was still very vigilant in how I felt, in watching my body, and even though I was optimistic, I never gave up that vigilance.
And you never have. You look wonderful.
Thank you.
And you're doing well, you say?
I'm doing very well.
Okay, we're going to talk about your treatment and the medications and all that in just a few seconds. Dr. Boyd, back to you. As far as the problems that can arise with the spread to the bone. Can you go into that?
Yes, the most common problem is pain because bone has a lot of nerve endings in it. It's very sensitive to irritation, such as when someone breaks a collarbone or breaks a leg. There's a lot of pain involved with that. And when a cancer involves the bone enough, and it may be that it takes at least 25 to 30% of the bone to be involved, pain can be one of the initial symptoms. The other thing that it does is it begins to move throughout this bone. It weakens the bone. Bones are there to help support your body against gravity, and with the force of gravity, a weakened bone will break, and then fractures become a problem. The other problem that may occur with bone involvement, bones are filled with calcium. That's where they get their support. And when cancers involve the bone, sometimes they release this calcium into the circulation, and the blood level of calcium rises to levels that can be dangerous, that can cause symptoms such as confusion and weakness and constipation. And left unattended, this high calcium level can be a life-threatening thing.
Well, let's go right into the symptoms now, and I believe we have a full-screen graphic with that as well. What symptoms are associated with cancer that has spread to the bone?
Well, and this is a good question because people have bone pain. It's a natural part of getting older. You have aches and pains, and how do you determine what is a significant pain, particularly if you have a history of a cancer? It's natural that when you have an ache or a pain to immediately think that this is cancer in the bone. And what are the characteristics of cancer in the bone that we can help educate our patients so they're not fearful if something like this happens? Cancer in the bone rarely, if ever, and I don't know exactly why, goes below the elbow or below the knee. And so if someone has pain in the ankle or pain in the wrist, pain in the knuckle or the foot, not to say it never happens, but it's very rare that it's related to cancer.
So it's going to be above the elbow,
and
above the knee?
Now, it's common for cancers to involve what we call the axial skeleton. That is the skull, the spine, the pelvis, the hips, the shoulders. Those are common areas. But for it to go below the knees or below the elbows is unusual.
How about arthritis?
Arthritis, of course, can hit the hands, which is common, but it also can involve the spine and the hips and the pelvis, and so people can have aches and pains there. And how do you distinguish that sort of arthritis from cancer? Sometimes it's difficult. But cancer pain usually is a relentless pain if untreated. It stays put in that area. It doesn't go away. It doesn't wax. It doesn't wane. It usually doesn't migrate from joint to joint to joint. Arthritic pain is migratory. You might have a pain in one hip one day and take an Advil, it goes away, and a day later it's in the shoulder and it's left the hip. And so that's how we try to distinguish the discomfort of arthritis from the potential of having cancer in that bone. Now, having a pain that persists in the bone doesn't mean the cancer is there. It just means it needs to be brought to our attention so we can do further studies. And the studies are varied, but we can discuss how we diagnose that in the bone.
Well, let's go right into the treatment for bone cancer. What are the treatments? We have another full screen for that, I believe.
Well, the treatments are to attack the cancer in the bone, and we often cannot remove it if it's in the spine or in the skull. It's in an area we can't really effectively surgically remove it in those areas, and so radiation therapy is used. Radiation is high energy radiation that is very accurate now. The radiation oncologist can pinpoint it to that area of the spine, say it's in the upper back or lower back or in the hips. And with about 2 weeks of treatment, it's adequate enough to really kill the cancer cells in that area and allow the bone to heal so the pain begins to go away. In some situations, the bone is so weakened, say it's in the hip bone, where it fractures or it's going to fracture, and we don't have time for radiation therapy to work. That's when orthopedic surgeons can go in and actually can remove a hip or put a rod into the hip to shore it up, to keep it from fracturing, and then later we can come back and give radiation therapy to further strengthen the bone. Other ways of treating cancer in the bone, besides radiation therapy and just surgically fixing that weakened bone, is to give treatment that effectively kills the cancer. And this can be a variety of chemotherapy drugs, which can be effective in breast cancer and lung cancer and multiple myeloma. Hormone therapy, which is an effective therapy in prostate cancer and in breast cancer, can also be effective in killing those cancer cells that are creating problems in the bone, allowing the bone then to heal and the pain to go away.
Okay, we also have another graphic for more treatment, and I want you to explain this too. In addition to this treatment relieving pain, the infusions. Explain this now.
Well, over the last, I guess, 7 or 8 years, we know that there have been medications. They're called bisphosphonates, and there are 2 listed there, zoledronic acid and pamidronate. Zametta is what number 1 is called, and
Zametta is a brand name.
It's a brand name. Iridia is a brand name for the pamidronate.
Iridia.
Iridia came out first. It was shown to reduce the complications of cancer that involve the bone, that is in multiple myeloma, and particularly in breast cancer. And this allowed the bone to heal. This type of drug impairs the ability of cancers to eat away at the bone. It's like, I guess it's like a harbor, and the cancer's a ship in the harbor, and this is a blockade. It keeps the cancer from getting out and doing damage. It allows then the bone to repair itself. And these bisphosphonates require infusions. The infusions with Iridia are generally 2 to 3 hours. Zametta, the new one, is over 15 minutes, so it has that advantage. Have been shown over the past decade to reduce the complications of bone involvement. It has reduced pain. It has reduced the incidence of fractures. Therefore, it has reduced having to have surgery and radiation therapy. There's also a body of evidence out there that we're just learning about. These drugs, these bisphosphonates, may also have a mild anti-cancer effect, particularly in multiple myeloma and possibly in breast cancer, where in addition to helping to rebuild the bone and prevent further damage to the bone, they may actually make the cancer cells die in the bone. And so that's encouraging.
It certainly sounds it is encouraging. Now, we have a picture of what bone cancer looks like. A doctor like yourself would only be able to explain to us what we're looking at, and I want you to try to do so.
Right. This is an X-ray of the chest, and actually half the chest, the left side of the chest. You can see that whitish area toward the lower left, which is the heart border. You can see the collarbone up at the top. And over to the left-hand side is the arm, the shoulder.
Right.
And that big bone that leads from the shoulder is called the humerus. And you'll see in the whiteness of that bone a dark area.
Yes, is that the cancer?
That is the cancer. And why that is dark is because X-rays basically are blocked by calcium. And so the film where the calcium is lighter. The X-ray does not penetrate as well. And so with the exposure of the film, that area is lighter. What has happened is the cancer has basically eaten away that part of the bone. It's removed the calcium from that bone. And so the X-rays go right through. And if you see under the arm there, blackness, that's air. In that hole in the bone, it's almost as black. It's almost like air is there. So it really has destroyed that portion of the bone.
Now, Dr. Boyd, is this an example? You were saying that calcium can actually, leak from the bone and it goes into the blood system. Is this what's called HCM? And what is that? And a drug like Zametta actually helps prevent that. Is that not correct?
Well, in certain cancers, the involvement of bone, multiple myeloma is one, breast can be very common. If there's extensive bone involvement, the cancer basically begins to dissolve the bone, to weaken the bone. As you can see in that X-ray, that area of blackness was bone that was dissolved away.
And that calcium goes into the bloodstream?
Goes into the bloodstream, and normally the kidneys are able to get rid of the calcium. But if the rate of bone dissolving is so high that the kidneys cannot compensate by getting rid of that calcium, the level of calcium builds up in the blood. And that's usually in people who have quite extensive bone involvement. The kidneys are not able, therefore, to to get rid of that excessive calcium, and what we call hypercalcemia develops, and the symptoms of hypercalcemia.
And that's the HCM.
Right.
Okay. And understand that that's also one of the highest or the most common life-threatening complications of bone cancer. Is that true?
It is. In certain situations, it's considered an oncologic emergency, and if the calcium level gets too high, it can be life-threatening. The patient has to be admitted to the hospital. Large quantities of intravenous fluids are given to help the kidney flush out the calcium, and medicines like Zametta and Iridia are then given to block the cancer cells from continuing to dissolve the bone and release calcium into the blood.
Now, can these drugs also prevent the spread of bone cancer?
Well, that's a good question. That's what some people are beginning to think, that giving these drugs like Zametta or Iridia, not only does it tend to strengthen the bone and prevent bony complications and certainly keep the calcium under control, there is some evidence that it actually may prevent the spread of cancer in the bone. Now, will it prevent the spread of cancer elsewhere in the body? We don't know, but certainly within the bone it seems to help prevent the spread.
Let's go back to you, Donna.
Okay.
Are you on one of these drugs that prevents the calcium from building up? Does this apply to you, or is your story differently?
Yes, I am on Iridia right now, but I will be going to the new drug on my next infusion. You get it every
Why?
4 weeks.
Why would you switch?
Dr. Boyd explained that the Zametta is a 15-minute infusion compared to a 1-hour infusion of Iridia, and it doesn't have the side effects. I do not handle the Iridia. My body does not handle the Iridia that well.
Well, what are the side effects?
Nausea.
Mm-hmm.
It's mostly a digestive discomfort, almost as if your esophagus is starting to swell.
Mm.
Like, sometimes I feel like maybe I'm going to have a heart attack.
Right.
It's just a terrible discomfort. Headache, flu-like symptoms.
How long does it last?
It usually lasts 5 days, and then it tapers off. I get chemo every Tuesday. And by Friday, I'm starting to feel better. By Saturday, much better. By Sunday, I'm fine. And it is unbelievable because you think, oh, what's happening to me? Everything's coming back. And then it wanes. And I'm ready for my chemo on Tuesday again.
So with the new drug, what do you expect?
I'm hoping that I won't have the side effects that I'm having with Iridia. And of course, 15 minutes compared to an hour is much less time in the chemo lab for me. It's generally an hour and a half. With Iridia, it's 2.5 to 3 hours. And now, with the 15-minute infusion, it will be a shorter amount of time.
What will be the side effects of this new drug? Do you know?
Well, they conceivably could be the same as Iridia, and Iridia can be given for a long duration, that is for many, many months, and for the vast majority of patients doesn't have any cumulative toxicity, although there's some kidney toxicity with these drugs.
So there's always the possibility of kidney failure.
Well, not total kidney failure, but impairment of kidney function, which is reversible when you stop the medicine. The symptoms that Donna is experiencing with Iridia, we hope will be lessened with this drug. Certainly the amount of drug, milligram-wise, is less, and we hope that she'll tolerate it a whole lot better.
When you were first diagnosed, what was your greatest fear?
Well, truthfully, I didn't have time for fear.
Now, Donna, let's keep in mind, this was 8 years ago.
Yes.
Okay.
And
let's put it into perspective.
I immediately, I was fearful. I have to admit, I was fearful. But I immediately called a very close relative who was a radiologist. I then made contact with Strang Cornell Medical Center, where a very dear friend is a breast cancer surgeon, and went for a second opinion.
I was going to ask you, did you go for that second?
Yes, yes. And they all recommended that I have a tram flap operation, which is a double mastectomy, taking the other breast for prevention, taking the tissue from your stomach, and remolding your breasts. It is a 10-hour operation. But everyone felt, including Dr. Geisinger, my surgeon, that the cancer was so microscopic that I would be fine. I would never see it again.
This was 1994.
Yes. And after the operation, I had 3 doctors. Dr. Geisinger, the surgeon, Dr. Mullis, a plastic surgeon, and Dr. His name escapes me,
That's
Jacobs,
okay.
I believe, from Charlotte Plastic Surgery. And then I went to see Dr. Jim Boyd.
So the relationship started with Dr. Boyd, and you went to him for follow-up treatment?
Yes.
And that's when, and you continue to be treated by him with these drugs?
No, I had no treatment at that time. I had 15 lymph nodes that were clear. And
so this was follow-up?
This was follow-up. Every 6 months I went to see Dr. Boyd, and we took tests, and we took scans. And 4 years later, I detected something. And Dr. Boyd, who is Johnny on the spot, right there, saw me immediately and said, "You're going in for a biopsy." And that was the second reoccurrence. And that's when it had metastasized to my upper thorax bone. And that was just the second reoccurrence. I went through chemo and radiation. It was very difficult treatments at that time. I lost my hair.
Not to mention the emotional aspect.
That's when I had real fear. That's when the fear of my mortality set in. And I must say that with the support of my family, my husband, my sons, my daughter-in-laws, and my friends, with Dr. Boyd and his staff, and with my spiritual guidance, which is so important to me, I got through that chemo and radiation. I lost every single hair on my head, but I wore hats and I dressed up to go to chemo as if I were going to a luncheon. And I got through the time period. And it was a year later that the cancer returned. I felt 2 little lymph nodes pop out in my neck.
This is 1998?
It's 1998 going into 1999. And it was in my pelvic area and had spread. And Dr. Boyd had, at the time that he gave me the chemo and radiation, said there's a new drug, Herceptin, and I'm wondering if we should give this to you. But I really didn't want to take another infusion of some sort. And my husband and I went to Australia for 6 weeks, and Dr. Boyd said, "You go and you enjoy yourself." And we did.
So how do you keep the quality of life now that you are on the medication, as opposed to saying, I'm throwing my hands up, no more infusions, I will continue to have the quality life that remains with me? Here you've taken it the step further with quality of life, I'm hearing you say, with the medication. How do you achieve that? What's your message to someone out there who may need to hear this?
Well, the Herceptin, in relation to the last chemo and radiation I took, is much easier. It's a wonder drug, and if you are receptive to it, it's a much easier infusion. You are uncomfortable maybe a day or two, and then the rest of the week is yours. And it's wonderful. And you have your hair, and you dress up and you go out with people and they look at you and you don't look like you're sick. You look fine. And then you go to the chemo lab on Tuesday, and I must say that the chemo nurses are my angels of mercy. I love every one of them, and I would love to mention them if we have time. I can't tell you, Mary, Linda, Penny, Sharon, and, wait, I have one more. Sharon and Gloria.
Wonderful.
And they are just fantastic, and so is Dr. Boyd.
Dr. Boyd, you have a patient here. I'm assuming that you would love to have her around every time you have to give the speech to someone.
She's wonderful.
That their cancer has spread to the bone.
Mm-hmm.
How does a patient, other than Donna here, take that news? It has to be a tremendous toll.
It is. Obviously, it's very difficult to be told that you have cancer. But as Donna said, it's much more difficult to be told that it's come back. I think that her relapse occurred at the time this new drug, Herceptin, came out, so we were very fortunate to have that. It has made such a difference in women's... Not every woman is eligible for Herceptin who has breast cancer, but about 25% are. And it's a great drug. It has some side effects, but for the vast majority of women, they tolerate it very well. We don't know how long to give it. As long as people are doing well, we will plan to continue to give it. And Donna has some friends there that sit with her in the chemo lab that every week is getting the same thing, and both of them are, and actually they're probably much more that other doctors have too, but both of them have developed a friendship, and they're doing great.
That's wonderful. We're going to take questions from our viewers. We are on tape tonight, but we do have questions from around the region. We're going to take a question from Joe in Mount Holly. And Joe asks, I have multiple myeloma. What do I need to watch for to see if my disease is in the remission or being controlled by all my medications? Dr. Boyd?
Well, multiple myeloma is a malignancy involving the bone and bone marrow. It's not that uncommon. It's more common in people over the age of 60, although we have younger patients with multiple myeloma. It does respond well to chemotherapy, and in some situations we do what is called stem cell transplants, which don't cure it, but can keep it into remission a bit longer. Certainly medicines like Zametta and Iridia are a very important aspect of the management of myeloma. As I mentioned, it does reduce the bone complications, and myeloma is very prone to high calcium levels in the blood, very prone to weakened bones and bone fractures. And these drugs, such as Zametta, really do a good job in helping prevent that. And they may also have an anti-cancer effect on multiple myeloma. So we use them quite extensively in our patients with multiple myeloma. Now, with multiple myeloma, the way that we can monitor disease often is simply with a blood test, measuring that. It's an abnormal protein that we can measure in the blood, and that's one good way of monitoring response and whether or not someone achieves a remission.
Let's take another question. This is from Gary in Lancaster. And Gary writes, I am currently being treated for prostate cancer. What are the warning signs that the cancer has spread to my bones? Is it pain always, or are there other symptoms?
Well, prostate cancer, of course, is very common. The older a man gets, the higher the probability, and so that men over the age of 80 probably... A lot of them have prostate cancer they don't even know about and will never know about, because many prostate cancers don't become symptomatic. But prostate cancer is a cancer that loves to go to the bones. And sometimes it's in the bones for quite a while and people don't know it. Men may not have pain, but after a period of time, it may be months or years, the cancer, if it's particularly slow-growing prostate cancer, then becomes manifest as pain, persistent pain in the pelvis or in the back, progressive fatigue, because the prostate cancer can involve not only the structural bone, but the bone marrow. And when it involves the bone marrow, the blood counts, such as the hemoglobin, can drop, and men can come in with profound anemia due to involvement of the bone marrow. But often pain is a presenting symptom for prostate cancer that has gone to the bone. And as I mentioned previously, it's typical persistent, relentless type of pain that stays in one spot for more than several weeks, pain that doesn't migrate to different parts of the body, such as arthritis does.
We're going to take our break. You're watching HealthWise here on WTVI.
An unrestricted educational grant for HealthWise is provided by Novartis Oncology, makers of femoral letrozole tablets used in the first line of treatment of metastatic breast cancer, and Zametta zoledronic acid, used in the treatment of the bone-related complications of cancer, in association with oncology specialists. If you would like support group information about tonight's topic or any other HealthWise topic, you may call SupportWorks at 331-9500. For more information about tonight's guests or upcoming HealthWise shows, please call the HealthWise information line at 371-8836.
For questions or comments, write to HealthWise, WTVI 42, 3242 Commonwealth Avenue, Charlotte, North Carolina, 28205, or email us at healthwise@wtvi.pbs.org.
Welcome back to HealthWise. I'm Joey Pop. We are having a very candid and eye-opening conversation today with a cancer patient, a cancer survivor, Donna Levin. Thank you so much for being here. Your cancer is in stage 4. It has spread to the bone, and you are living a quality life, you tell us.
Yes.
We're going to talk more about that. And her doctor, Dr. Jim Boyd, oncology specialist here in Charlotte. We were talking about the different cancers, and I want to get back to the treatment in advanced cancer, and I believe we have a full screen for this as well. Quality of life. Those are 3 key words, are they not?
They're very, very important words, yes. Yes. When someone has advanced cancer, although some advanced cancers, if you want to use the term stage 4 cancers, are curable, such as testicular or lymphomas, many stage 4 advanced cancers are not. And so what we try to provide is quality of life. Not only prolonged life, and we certainly think we do that and we wish to do that, but whatever time a person has left, we don't want to destroy it with side effects of treatment. And so we try to come up with treatment regimens that will provide a person a fairly normal life, where a person can look normal, and that's called palliation. Palliation is just a medical term, meaning that you're relieving symptoms, making a quality of life better. I can remember when I started training in oncology in the 1970s, the focus wasn't on quality of life. The focus was on just seeing if the drugs work. And we made a lot of people sick. And we really didn't improve their quality of life, and we didn't improve their survival. And chemotherapy really got a bad name at that time. And only now is it sort of digging out from that very poor reputation and the fear factor that comes with the term chemotherapy. So I think over the past 10 years, we really have been focusing on different treatments to improve pain management, to prevent complications of bone involvement. Fatigue is such a major part of people who are getting treatment. And Donna has some fatigue, but she gets over that. But some people live with chronic fatigue from their treatment. And
that has to be so tough to see.
It really is, because pain may be managed, the disease actually may be responding to treatment, but the fatigue is relentless, and people can't do the things they want to do. It can affect marriages, it can affect job, it can affect other relationships. And so we're really focusing on ways now to deal with the fatigue. We have one cause of fatigue is a low hemoglobin, anemia. There are medicines out there that can raise the hemoglobin to normal range. And in some people, this makes a big difference in fatigue. But in others, it doesn't. It's just the toxicity of the treatment. despite normal blood counts, that can lead to fatigue. And so we're trying to figure out what causes that fatigue. Of course, if we find that, we can help people with other fatigue besides cancer fatigue, and give them treatment to help their quality of life.
Donna, are you in pain?
I am in discomfort, but the discomfort could have nothing to do with my cancer. I have arthritis in my hands. I ache when the weather changes, but to actually say I have pelvic pain, I have never had that. I do have discomfort, terrible discomfort from
Chronic?
post-radiation. Yes.
Chronic.
Chronic.
Sitting here
Chronic.
right now, is it
No.
discomfort for you?
I
Is it-
took 2 Advil before I came here, and I'm fine. No, I do not have discomfort right now. And it comes and goes, and as Dr. Boyd said, you take Advil and it disappears. That's not necessarily your cancer. I do not have bone pain in my pelvic where the cancer is. I have not felt that. I can bend. I can do most normal getting into a car, getting out of a car. Maybe I get out a little slower than I used to, but I don't have problems doing that. I think it's more arthritis connected than my bone cancer. The most discomfort I feel is my post-radiation around my breast.
What can't you do that you would really like to do? Can you exercise? Can you go for walks? Can you clean the house if you want?
Yes, I do clean the house. I do make my bed. I do the laundry. Even in the worst of my chemo days, I got up, I got dressed, I made my bed, I did the laundry, and I kept myself busy.
You kept yourself busy.
In the house. And those were the worst of my chemo days going back 2 or 3 years. This chemo, Herceptin, is totally different. I can do just about anything. I am married to my husband Norman, 45 years now, and he is a very high energy guy. And we were out for 3 hours yesterday afternoon, and I was at the Hope Builders walk run at 8 o'clock in the morning. My dear friends, Maddie and Mark Silverman, have the Hope Builders walk run in memory of their son, David Silverman, who had a brain tumor. And my husband and I were both there for that walk run. I had a very busy day yesterday, and I did fine.
And you look so rested now.
I feel rested.
What type, are you involved with support groups? Are you in connection with other cancer patients? I would think that you're just a great inspiration.
I am not in touch with other cancer groups right now because I do get the chemo every week. And Tuesday and Wednesday, I do not have the quality of life. And it takes me a gradual build-up, and we are very busy socially. My counselor is a spiritual advisor, Rabbi Judy Schindler, and she has helped me through the very worst of times. And I just have a wonderful feeling about myself with her help, and I'm hoping that being on the television at this time, I can offer inspiration to breast cancer survivors and those who have newly discovered their breast cancer.
I bet you get some calls. Let's take another question from Monroe this time. We have a question from Doris. She sent to us. I am 68 years old and on Medicare. I have breast cancer with bone metastasis. Will Medicare pay for Zametta in North Carolina? Dr. Boyd.
Well, that's a very timely question because Zametta just was released by the FDA for high calcium, hypercalcemia, and the high calcium levels in the blood. Recently, North Carolina Medicare has approved the use of Zametta for involvement of bone by breast cancer and multiple myeloma. I think there are only 2 states in the United States where Medicare, the local Medicare carrier, has approved the use of Zametta for this indication. And yes, Medicare...
Why wouldn't they approve? Is this FDA approved yet?
It's FDA approved for high calcium. But we know that many drugs are used off-label, so to speak, that are very effective drugs that don't require FDA approval. But sometimes Medicare will require that before they allow the drugs. Not all the time, but sometimes. And it's up to the local carrier. The North Carolina Medicare carrier has decided that this is, based on good, sound scientific evidence, this is a good drug for cancer that has spread to the bone, and therefore has approved it. Medicare will pay for 80% of the drug. If that person has a supplemental, a Medicare supplement, that supplement will usually cover the remaining or part of the remaining 20%. So Medicare does not pay for the entire drug, but it pays for 80% of the drug.
Let's take one more question here while we have our questions. This is Liz from Charlotte. I have bone cancer. How is this different from bone metastasis, which is the spread of cancer, correct?
Right, and there's often some confusion. In fact, if a cancer spreads to another organ, say it arises in the colon and spreads to the lung, some people think that that's lung cancer. It's colon cancer, but it has metastasized to the lung. If a woman has breast cancer and it spreads to the bone, it's still breast cancer, but has metastasized to the bone. And so that is a metastasis. It has originated in one part of the body and has spread to another part, in this situation, the bone. There are conditions, there are malignancies that actually arise in the bone as their primary site. Multiple myeloma, which I mentioned, does arise in the bone. There are actually what we call sarcomas, osteosarcoma, which is a different type of cancer that usually occurs in young men and women, teenagers, that is a primary bone cancer. There are cancers that arise in the cartilage part of the bone. Those are rare compared to multiple myeloma. So when we say something is a bone cancer, we mean that that has arisen. That's the site of origin, the bone. When we say something is a metastasis, it has spread from somewhere else to the bone.
Donna, you were talking about support and family and friends. That has to be just a tremendous boost for you. But in return, what have you given back to them?
Well, I like to think that I have given them my friendship by joining in their special occasions, their birthdays, their anniversaries, the birth of their grandchildren. I try to be at every happy occasion of not only my friends, but my family, if I possibly can. My cousins who are all over the country, and Norman's cousins who are all over the country. We both have a greater appreciation of the people who have given me their energy and have helped me in my recovery. And we try to return this in our kindness to them in their happiness and in their sadness when they lose a loved one. We are there.
When you were first diagnosed, were you working?
No, I'm retired.
You were retired
Yes.
when you were diagnosed.
Yes.
For someone who may be diagnosed, and if they are working, would they be able to continue work during the treatment process? And Dr. Boyd, I'm going to have you answer that as well.
Yes.
Donna, let's go with you first.
I would say if you're on Herceptin, that yes, I feel that you could continue with your work. If you were on the adriamycin and taxotere I was on the second time around, it would depend on what kind of work you do, because your counts drop so drastically and you have severe fatigue. But there are women who do work in this time frame that I talk to in the chemo labs.
Dr. Boyd?
As Donna said, working while on chemotherapy can be very difficult, not only because the blood counts can sometimes go very low, and by that I mean the white blood cell count, which when it drops below a certain level can lead to a high risk of infection, and people are worried about picking up infections in the workplace, people with colds, that sort of thing. But also profound fatigue. And for some jobs that are particularly physically or emotionally demanding jobs, that fatigue can really interfere with their ability to carry out their work. There can also be nausea and vomiting, which also does interfere with someone's ability to work. Some chemotherapy regimens don't have that, and men and women with cancer while receiving chemo can continue to work. Sometimes they alter their work schedule. They're able to come in a little bit later in the morning. The day that they get chemotherapy, they may be allowed to take that day off. It depends on the job, it depends on the drug schedule, and it depends on their employer, how, I guess, understanding and how willing the employer is to accommodate that patient.
Let's take another question. This one question comes from Gastonia, from John. John writes, I have prostate cancer. How does cancer eat away and affect my bones?
Well, that's, prostate cancer, of course, is a common cancer that spreads to the bone. And I want to kind of make a distinction here between types of effect or different effects that cancer has on the bone. The one that we worry about the most is where cancer, as John referred to, eats away at the bone. It has certain cancer cells in the bone have enzymes, digestive substances that can actually dissolve the bone, releasing the calcium into the bloodstream and weakening the bones. Some cancers, particularly slower growing cancers, and sometimes prostate cancer and breast cancer can be slow, the bone actually reacts to the cancer by building more bone, and so the bone actually gets thicker rather than thinner. And sometimes it's mixed. In a person with prostate cancer that's spread to the bone, there can be areas of the bone where the bone is very dense, very thick, and there can be areas of the bone where the bone is thinned out and prone to fracture. But the way cancer cells, we think, do this to the bone, where they actually dissolve the bone, is through substances that the cancer makes. These are substances very similar to what we call the parathyroid hormone that we all naturally make in the parathyroid gland, which is amongst the thyroid tissue. But it makes too much of this, and so it dissolves or destroys bone by the production of this particular enzyme that will do that. Drugs like Zametta will tend to block that and prevent the bone from being dissolved.
Well, we saw the picture of the hole that looked like was actually in the bone. How is that diagnosed? Through an X-ray, if the calcium is eating away?
Yes. Now, the cancer needs to really be fairly substantially involving the bone to see it on a plain X-ray like that. And it was clear cut on that X-ray.
And there it is again. So is that a stage 4 cancer?
It is a stage 4, and probably with that size of involvement, that person is feeling it. I would expect that there would be pain in the upper arm in that patient.
Is that literally a hole in his bone?
Well, it's filled with cancer cells. It's not an empty hole, but instead of normal bone and instead of normal calcium, there are cancer cells that are filling that hole. And cancer cells do not support the bone, and if someone were to lift a heavy object with that arm, they may break the arm.
Wow. And then what is the treatment for someone who has been diagnosed with such a condition, having that much cancer in the bone?
Well, one effective treatment, I think, is certainly, we talked about the bisphosphonate drugs like Zametta, but also radiation therapy can kill the cancer cells that fill up that hole. And the Zametta can be used to help rebuild the bone in that area. Now, if that bone looks like it's about to break, then we probably ought to get the orthopedic surgeon in to try to fix it before it breaks.
Okay. Let's go to another question from our viewers. This is from Huntersville. Kathy writes, I am 62 years old and have recently been diagnosed with breast cancer. Should I consider a lumpectomy or a mastectomy?
Well, we're getting into the treatment of breast cancer here.
And I'm sure this is something that you hear a lot, is it not? And Donna, you can relate with this.
The question is whether a woman who has recently been diagnosed as having a breast cancer, would that woman be best served with a lumpectomy or a mastectomy? A lumpectomy meaning removing that cancer with a margin of normal tissue around it and then receiving radiation therapy. A mastectomy, of course, meaning removing the entire breast tissue and often removing the lymph nodes under the arm with it. There are a lot of lumpectomies are being done in the Charlotte area and around the United States because women, for the most part, are having their breast cancers detected very early. They're aware of what to watch out for. A lump is not ignored. Mammograms pick things up early. And so in that situation where a good cosmetic result can be achieved by removing breast tissue with the cancer, then I think most women would be candidates for breast conservation, that is lumpectomy. Occasionally the cancer is so much involved in the breast that the surgeon cannot get around that cancer without a major deformity being created in the breast. And because that is poor cosmetic result, then the best approach is to do a mastectomy and reconstruction. There are women, though, who feel more comfortable with having a mastectomy. They don't have to worry about that breast anymore. Women who may have a high risk of getting a new breast cancer based upon some of the findings at the time of biopsy, based upon perhaps a strong family history of breast cancer. That woman may, even though she may be a candidate for breast conservation, may feel more comfortable with having the breast removed and not having to worry about a new cancer forming in that breast.
Donna, how difficult of a decision was it for you when you went for the total mastectomy? And still the cancer returned.
Yes. I don't look back, though, at something like that. I look forward.
Good.
I do not look back. But I was in such shock. I couldn't believe that this happened to me. It was like, this is impossible. I don't have breast cancer in my family. This couldn't possibly happen to me. But after talking to our cousins in Pennsylvania, and Cousin Barry is a radiologist, and to Dr. Rasha Simmons at Strang Cornell Medical Center, they encouraged me. And since I was so close to both of them, they encouraged me to go ahead with this operation. And I came back, and Dr. Mullis also at Charlotte Plastic Surgery had encouraged me. And that was it. I had the operation.
And like you say, you look ahead.
I look ahead. I don't look back. Exactly.
How important is it to have this attitude that you have, which is so positive?
It's very important, because when you have a positive attitude, life is beautiful. Every day is beautiful, whether it rains or whether the sun shines out. The trees, the sky, the birds, a butterfly, and I do believe in the angels. They're very much a part of my support system. And life is beautiful for me, and I have so many to thank for it. And I would like to give back one of these days to the many breast cancer patients who are out there. If I can be an inspiration, I will try very hard to give them this positive energy.
Well, I'm sure you have in the last hour. We thank you so much for that. We have time for another question. This is from Ramona in Charlotte. I've heard that certain foods and vitamins can help to prevent breast cancer. What are they? And I was going to ask you, Donna, do you take vitamins and supplements in addition to your medication? Dr. Boyd, I'm going to start with you first. Are there certain foods that will help prevent cancer?
Well, that has been looked at, and there's a lot of controversy over dietary influence on cancer. We've, for a long time, felt that a high-fat, low-fiber diet increased the risk of colon cancer, because in Africa, where there's low fat and where there's a very high fiber diet, colon cancer is very rare, but very common with the Western diet. And yet, when we've done these studies, and there were studies that we actually participated in here in Charlotte, that wasn't found to be so. We were believing that perhaps a high-fat diet increased the risk of breast cancer. We haven't conclusively found that. We'd love to find something like that, because simply by modifying your diet, you might really reduce the risk of any cancer, but again, that's not been shown. Over the years, though, there has been a hint that a diet that's high in fruits and vegetables has less cancer risk. Why that is probably because there's more than just vitamins that are involved. We do know that vegetables have a lot of other substances such as lycopene, antioxidants, and other things that we don't even know yet that may play a role in healthy cells in the body. So I've just advocated a diet that's high in fruits and vegetables, which is sort of hard to do, You can eat meats. Watch the fats because of the coronary artery problems with that. But make your diet diverse. Make it high in fruits and vegetables.
Very quickly, Donna, have you been on vitamins and supplements in addition to the treatment?
Yes, I do take a multivitamin for women, and I do try to eat a fairly good diet of vegetables and fruits.
Very good. Donna Levin, thank you so much for being here today. What an inspiration. Dr. Jim Boyd, thank you so much.
Thank you.
Join us next time on HealthWise. I'm Joey Pop, and thank you for tuning in. We hope this show has helped you become more HealthWise.
If you would like support group information about tonight's topic or any other HealthWise topic, you may call SupportWorks at 331-9500. For more information about tonight's guests or upcoming HealthWise shows, please call the HealthWise information line at 371-8836. Views expressed on HealthWise are those of the participants. An unrestricted educational grant for HealthWise is provided by Novartis Oncology, makers of femoral letrozole tablets used in the first line of treatment of metastatic breast cancer, and Zametta zoledronic acid used in the treatment of the bone-related complications of cancer, in association with oncology specialists.